Thank you so much, Cam. It's a pleasure for me to be here today. If I can ask that my second screen also go live as well? Perfect. Thank you. And so I actually have a presentation partner today. We're going to talk to you today about how your voice matters and how your voice makes a real difference when it comes to advocating for treatment and getting what you want. So the objectives of today's session is really, we just want to provide an outline of the system. What is the system and the process that is used to evaluate innovative therapies, those new drugs like zanubrutinib and ibrutinib, that as to how they get public coverage in Canada. And that process is called technology assessment. And then we really want to highlight the role of patients and your voice in evaluating public reimbursement and treatments. So today we are your presentation partners. My name is Christina Sit and I work for the Leukemia and Lymphoma Society, as Cam was saying, and then my presentation and partner Hailey Hill, who is the Drug Access Navigator and Director of Media at ACODANA. So we are going to collectively go through today. I will talk about the system and Hailey will talk about and give you individual tips and strategies on how you can get your access to treatment. Just for those that don't know LLSC a little bit, where our mission is really to cure all blood cancers and improve the quality of life of those undergoing a blood cancer experience and their families. At the Leukemia and Lymphoma Society of Canada, we are the largest blood cancer organization in Canada, and we serve the entirety of the 137 different subtypes of blood cancers. And so when we talk about treatment and getting what you want, we've really made tremendous strides. In this age, we have immunotherapy and, there's something called CAR T. There's precision oncology for treatment. And if you look at it, there was a big, large umbrella trial that's done for something called NTRK fusions. And you know what? And when I was at a conference a couple of weeks ago, they were even talking about taking a look at the levels of expression in your individual cells of certain receptors and saying, oh my goodness, that can put this person at risk for certain side effects. So maybe we can dial back some of those so that these people don't have to have a severe side effects. For those that have looked at a little bit about the news that was about the Princess Margaret gala last night, when the speakers was saying, in the last 5 years, in the last 5 to 10 years, we've made more strides in oncology than we have had in the last 50. So there has been tremendous innovation. But there are tremendous barriers as well. You guys all know too well, ibrutinib, Health Canada approved in April of 2016. CADTH made a not recommended for reimbursement in 2016. And, it had to refile. It had to refile 7 years later, and that recommendation is still pending. But, take that, contrast with that with the case of zanubrutinib. Health Canada approved that in March of 2021. And so CADTH in December 2021 recommended it for reimbursement. So how is that relatively fast? What is the process there? And then we have those that are really big outliers. I just wanted to highlight the case of nelarabine. Nelarabine is a treatment for pediatric ALL. So it was filed 5,800 days ago, and it got Health Canada approval then. But it just got a positive recommendation for reimbursement 5,800 days later, last month. And, that's 15 years. And if this is a drug for pediatric ALL, that is longer than these kids have been alive. So when we look at the delays and why is that, we can really bucket that into different areas. One is the uncertainty of the information and what the reimbursement bodies feel is uncertainty of the data. So in the case of ibrutinib, they thought it was 2 single-arm studies, so they thought that the side effects were didn't allow for the balance to have benefit for the patients. And for the patient organization did do an input at that point, and they said, the patient organization was able to recruit more patients and more patient voices than the study itself. So they found major problems in this study. in our system issues. In 2016, it was just the dawn of the era of targeted therapies and this era of single arm studies and really working with small populations. So the system hadn't quite caught up yet. And then economic evaluations and economic issues all contribute to the cost of delay as well. So I'm going to go into that one by one, but I'm going to talk about, how we as a patient community, because we don't run the studies and we don't set the price, but we have a voice. And the patient organization has a tremendous voice in achieving public coverage. And to illustrate that, I'm just going to talk about the pathway of drug access and who does what. And so in Health Canada, when before I started in this space, I thought that Health Canada approved the drug and of course we should have access the next day. And then when I started in this space, I found out really that wasn't the case. And Health Canada approves the drug, but it really just looks at, does it work and is it safe? So then that goes off, that it checks those boxes, then it receives a indication of a notice of compliance, is what we might say. Then it goes off to this group called CADTH, the Canadian Agency for Drugs and Technology in Health. And on the Quebec side, it's called INES. And so they look at what is called value. Is the benefit good enough? Does it meet enough patient values so that it should be publicly reimbursed? So it looks at that value of, is it worth it? Should I buy it? And then if they give a positive recommendation, it usually goes to this group called the Pan-Canadian Pharmaceutical Alliance, PCPA. PCPA is a group of where the provinces all kind of come together. They select one negotiator and they negotiate with the manufacturer on pricing. After that is completed, there's a signal on that, and there's called a letter of intent, what we call the LOI. After the LOI is signed by all the provinces, then it goes to the individual provinces to look at that implementation. And they'll say, okay, I can pick that up. One province might say, I can pick that up now and I will list it on my formulary so it can be available for patients the next day. But others might say, you know what, I can't fit it into the budget this year. We'll have to take a look at it in subsequent budget years. So that in an overview is how we get from Health Canada approval to individual provinces covering it. But where do we have a voice? And we have a voice in the CADTH process. The CADTH process does allow for patient group input. And when you look at the CADTH deliberative framework, it is deliberated on by a group called PERC, the Pan-Canadian Evidence Review Committee. And so they look at things within 4 quadrants. And so the 4 quadrants of PERC are what they call the clinical benefit. What is the strength of the trial? They look at what the price costs, and then they look at what the adoption feasibility. Can it be implemented into our systems? What sort of test does it need? What sort of equipment does it need? And then there's this column called patient-based values. And that is where patient organizations are invited to submit input. In that economic evaluation, they really take things very carefully. And this is the reason why some of our drugs take a little bit longer, is that idea of cost. In 2012, the average 28-day cost of a cancer treatment was 5,090 days. And then in 2021, the average cost of 28-day cost of cancer treatment rose to 13,478. Now, if you look at the overall statistics of the amount of money that the cancer treatments are taking within the overall healthcare budget, that is also rising. So that does take into that these costs are a very big consideration for the committees as they're looking at the sustainability of our system. So where is the opportunity? Where is that opportunity for us as patient organizations and patients to kind of tilt that value, that balance? Where can we take it to help tilt it so they're looking at value and not so much on the price? Well, it's in our voice, because these are the traditional study results that the committees are looking at. But what we do as patient organizations, when we do our patient organization submissions, is we reveal the real people values behind the data. So you may see something like median time of response was 5 weeks. But what we as patient organizations say is it works relatively fast. It helps people regain movement or functionality. People might say that corticosteroid doses were reduced in 65% of the patients, but the real people value really means it's a reduction in ward rage. It can help people improve sleep and function. So these are some of the questions that they ask us, and compared to previous therapies, what are the advantages and disadvantages? How did it impact the lives of patients, caregivers, and families? These are all questions and all things that are not measured in the clinical trials. So how are the side effects? Does it really impact life? So how do we capture those things at LLSC? So I'm just going to talk a little bit about our process for capturing patient group submissions and doing them. And we've done quite a bit in the last year. We've participated in 6. And so our methodology is really to look at a very structured series, and we look and we see, can we interview the patient? We really want to hear the voices of the community that's impacted. And so and then from there we pull out the themes. We throw out the themes from the survey and we validate them into a survey, and then we create and craft the submission. So using the 3-prong process and the idea of and the case of study example with those living with chronic GVHD, we interviewed some patients, and we noted that the chronic burden and of course the chronic theme of receiving steroids. So we really looked at the experience of steroids and what would it mean to those that when you didn't have to be on steroids anymore. And so, yeah. From there, we were really able to pull out the real people values from there. And these are the types of statements that we make in our submissions. So I get asked this question all the time. Are you just a checkbox? We do all this work. Are we just a checkbox for the organizations that just say, we've consulted with patients? And I can really say no, because there have been cases where I've worked on 3 cases where patient organizations have really been able to tilt the balance and say, from a negative recommendation, when we've asked for reconsideration, our voices have been able to convert it to the positive recommendation. We've been able to expand a recommendation to say, the data didn't look at this, but this is an impact on patients as well, because we were able to show the real life impact. Have we been able to do it all the time? No. And when has it been able to make a difference? It's been able to make a difference really in the case where the evidence has been on the bubble. They're thinking, we see a clinical signal. We see that it makes a difference in the lives of patients. We're just not sure. And when it becomes, they're not sure, that's when we can really push it over and make it into a positive recommendation. So I really just want to say that your voice matters. When there's these calls for submissions, really participate in the process. And there is that power of partnership within the patient community. We have to show the regulatory bodies, the patient, not as a patient, but as a person. And there is the power of data. So we as patient organizations and patients, we really have to recognize that we have we are able, in like many countries, to be able to have our treatments publicly covered. And so when we do, and we were asked, can you contribute your data and your experience in order for us to understand how this treatment works in real life? We really do have a social responsibility and to say yes, and to really help these regulatory bodies and say, you know what, we did something good. We recommended this treatment for reimbursement, and it really is working in the patients and making a difference in the lives of patients. So I'm going to pause here, and I'm going to turn it over to my presentation partner, Hailey. And Hailey Hill will go through the how you get access to treatment as an individual.
Hi, everyone. Thank you so much for having me here today. My name is Hailey Hill. I am a registered pharmacy technician. I just want to thank my counterpart here, Christina. She did an excellent presentation laying the floor for how drugs are funded within Canada, and I will elaborate that a little bit more. So today I'm going to do a presentation, which is an overview on Oncology Drug Access Navigators. Specifically, I work as a Hematology Drug Access Navigator. So a little bit of information about me. Like I said, my name is Hailey Hill, previously Stewart. I just got married a few months ago. Like I said, I'm a registered pharmacy technician here in Nova Scotia. I have 2 years experience as a Hematology Drug Access Navigator. I have over 10 years of experience in retail pharmacy, along with 7 years of experience of hospital pharmacy. And I'm also a member and director of media for ACODANA. And we'll get into that in a little bit. I'm sure you're curious what that means. And then just my little happiness story I like to share when I do these presentations. Over here on the left, we have some photos. So my passion for hematology began back in 2019. One of my very close friends from high school, her spouse was diagnosed with ALL. He was quite young then. I believe he was 26. And in July of 2023, we got to celebrate their marriage, and it was on their daughter's first birthday. And just a little bit of disclosures to go over here. My education and background, I work in healthcare, but I am certainly not a physician, so I can't provide any clinical information or recommendations. I'm doing this presentation on behalf of ACODANA. I'm not affiliated with any companies or speaking on behalf of my employer. And the information I'll be presenting are based on my opinions working as a drug access navigator. And some of the topics that we'll go over today, what are drug access navigators? We'll do an introduction to ACODANA, support across Canada, and how to access. We'll chat about patient support programs. What are they? What do they offer? And we'll talk about drug coverage, provincial and public funding, private drug coverage, and a little bit of the pain points and CADF. So now I'll get into what is ACODANA. So ACODANA is the Atlantic Canada Oncology Drug Access Navigator Association. And our mission is to support and enhance the voice of oncology drug access navigators working in Atlantic Canada with the aim of maximizing patients' access to cancer-related treatment. Our vision is to create a network of oncology drug access navigators with educational opportunities, information sharing, and through support, we aim to improve the quality and availability of drug access navigation services throughout the region. Our values, the association was officially formed in December of 2019 as a registered nonprofit, although drug access navigators have existed for many years before that. The official formation was not that long ago. ACODANA is not a professional registry or a licensing body for drug access navigators. We simply aim to be a central hub of communication for those working in the field and to have a voice on drug access issues within the region. And our work aligns with the work of other oncology drug access navigator groups, such as the Ontario Drug Access Navigator Association. So, what are drug access navigators? Why did our role begin? Over the years, oncology clinics have been facing many challenges with drug coverage and reimbursement. With the increase of research and demand of new oral and systemic therapies, how do we get access to these medications? Why is there such a delay in patients being able to access this as opposed to when they should be able to start treatment? What is our role? Each navigator's role may vary based on their scope of practice and provincial regulations, but our vision remains the same across Canada, which is to help patients get seamless treatment they need in the most time effective and cost-effective manner. What is our background? Our background may vary, but most commonly we have education and experience in areas such as pharmacy technicians, pharmacists, social workers, and nursing. What can drug access navigators do for you? So in a typical day, what we would do with the healthcare team and alongside with the patient is we investigate coverage details, conduct three-way calls with patients and their insurance provider. We help the physician with prior authorization forms and formulary exception requests. We assist physicians with appeals in the event that coverage is denied, and we assist patients with coverage renewals so that there are no gaps in their treatment. We assist patients with enrolling into patient support programs, with applications to the Preventive Drug Program. We advocate for patients for timeless and seamless access. We explore all possibilities of drug funding. We help reduce that financial burden associated with your treatment and help reduce that anxiety by assisting through the navigation process. Because as we all know, there's a lot of complicated channels and routes, and it's hard enough for me to keep track of it all, let alone for you guys. So we are here to help you. In Canada, there are navigators across the country. We do have some organizations, like I had mentioned previously. We have ACODANA in Ontario. And over the last few years, we've had more drug access navigators join in British Columbia and Alberta. At this time, I don't think they have a formal association, but the job is certainly growing. In Quebec, they also have their own association, and in Atlantic Canada, we have ACODANA. And just over here on the right, I have some links to the association websites. You'll be able to have these slides afterwards, and you can explore the websites. A really good reference is the Drug Access Canada website. This is a good informational site for patients, caregivers, and healthcare professionals. I think it does a great job explaining the different types of drug coverage and funding, as well as there are some great resources there. So I encourage you to take a view through those websites. What is a patient support program? I'll also refer to it as a PSP. So if I say that, I mean patient support program. So as patients with Waldenstrom's, I'm sure many of you, if not all of you, have heard of patient support programs. You've either been enrolled into one or heard of one. I'm sure you've all have some sort of experience that you can relate to. So a patient support program is a program developed and paid for by a pharmaceutical company that makes that specific drug. And their goal is to support patients in taking their medication. In Atlantic Canada, each patient that is referred to a DAN is assessed and enrolled into a patient support program if and when available. Unless the patient declines consent, we would enroll them no matter what their coverage situation is. And some of the things that patient support programs can offer patients are they also help with the reimbursement navigation process, very similarly to what drug access navigators do. They are potentially able to provide financial assistance, certainly with offerings varying by company and by province. And they offer various services such as nursing services, pharmacy services, and infusion clinics. And now the good part. How are drugs funded in Canada? I wish I could give you a simple answer, but essentially drugs in Canada are funded through various different methods. Although we would expect it to be easy, it is not. Drugs that are provided in hospital are paid for by the hospital at no cost to the patient. With the exclusion of some of the formularies and different treatment options. But typically when you are admitted to hospital or receiving a treatment in hospital, those you would not have to pay for those treatments. Whereas drugs that are taken outside of the hospital, coverage is the responsibility of the patient. And that can be either by a public drug program or private health insurance. In each province in Canada, there's a public drug funding program. So essentially, the federal government gives the provincial government X amount of dollars to run their public drug program. And so it's up to the provincial government to decide what drugs they want to cover, if it's going to need pre-approval, if you should try certain lines of medication first before taking this medication. So essentially, it's up to the province to decide how they want to do it. And that is why we have so much variance across Canada. So there's talk about implementing a universal pharmacare, which has its pros and cons, obviously, but at this time, that's why there's such a wide variety of coverage. And private health insurance simply refers to health coverage that is not offered by a provincial or federal government. I meant to put a little bit of info on here, but I will touch on it. The federal government also provides drug coverage for certain groups of people, such as refugees and inmates that are incarcerated. And some of the other sources of drug funding, sometimes there is unfortunately the out-of-pocket expense for patients. There is the Special Access Program of Canada, which essentially means that there is a drug on the market in other countries in the world, but it is not approved by Health Canada for use in Canada. So your physician would do up a request to Health Canada to bring this medication in, explaining why it would benefit you and so on. And if Health Canada approves, then they are able to bring this medication in specifically to Canada. I want to touch on clinical trials because clinical trials are a very important option of care. We sometimes turn an eye to clinical trials because of the unknown when we're hearing phase 1 or phase 2, but they are definitely a valid treatment option. And if you're eligible for a clinical trial, you might be able to access a medication that you wouldn't normally be able to access at this time in Canada. And then finally, patient support programs. They help gap that bridge between when a new drug comes to the market in Canada and when it's going through the process with CADTH. So patient support programs typically can assist by offering financial assistance and or compassionate or bridging supply while they submit to CADTH for their recommendation on drug funding. So, in summary, our role in education varies widely, but our vision remains the same. Drug coverage is not universal in Canada. Drug access navigators are an excellent resource for patients and physicians. Ultimately, the physician is the one who makes the final decision on a treatment plan. Drug access navigators are just there to assist in the process. And lastly, I just want to encourage you, if you ever have any questions about your drug coverage, your copay, if anything doesn't seem right, ask your healthcare team. You are a huge advocate in your own treatment plan, and so often we see patients just take an answer because that's what you're given. But I encourage you to poke and prod and ask your healthcare team to have a referral to a drug access navigator. Sometimes there's not an opportunity to provide further assistance, but sometimes there are channels that physicians just don't know about. So please reach out and ask. And finally, I just want to say thank you so much for having me here today. It's been a pleasure chatting with you guys. And if you want to follow our ACODANA website, the link is over there on the right side. You can also send me an email, although I cannot specifically help you. I can provide information on our role and about ACODANA.
Thank you so much, Haley. I think we're bring back in live, and I think Haley and I are happy to answer any questions and engage in a little bit of a discussion. You can submit questions through the chat, I believe that's correct. And we were also given some questions before the session started. So I'm going to ask, and maybe Haley and I can engage in a little bit of a discussion on those. But just before we start, I just want to reiterate that neither Haley nor I are healthcare professionals. We cannot comment on your individual situation, and we encourage you to speak to your doctor, but we can speak to the systems and the process issues in general. So, Haley, we were given a question before this session started, and a question was submitted on, hey, there's a really promising therapy that's coming up. And it's got really promising data, and it looks like in 2024 it will get FDA approval. So the question was, how can we encourage Health Canada to take up this file quicker, and how can Canadians get access to this treatment faster? So maybe I'll kick that off, Haley, and from a systems perspective, and then I'll pass it over to you to speak from an individual perspective. Sound good?
Yeah.
Yeah. So from a system perspective, when drugs come up for approval, they have to be filed by the manufacturer. So as a patient organization, what we can do, and as a group of patients, we can encourage the manufacturer to file for this drug, and we can ask that and band together with our clinicians to encourage filing. And ultimately it is up to the manufacturer to make that decision, and they make that decision based on, quite frankly, how much money there's an economic component in this. What is the size of the market here in Canada, the ease of which they think they can get coverage, and supply availability as well. Typically, the Europeans and the US are the first to get access to a treatment, and then Canada follows very quickly soon after. In some cases, I've already actually seen Health Canada approve a drug before the FDA has approved a drug. Now, there are mechanisms. The governing bodies do recognize that some of these medications are really, really needed for Canadians, and they established a new process called Project Orbis. Project Orbis is an initiative, a collaborative initiative with the FDA, with now Switzerland and New Zealand and Australia, and where Canada participates in the simultaneous approval of these treatments. So while each governing body still approves it separately and makes a decision based on their own criteria and their own population, there is a streamlined process that the manufacturers then can use to submit, and the information gets to all of the governing bodies, and then they sometimes collaborate and consult each other. So I'm going to turn it over to Haley. Haley, what are your thoughts on how they can get access to treatments faster?
Yeah, definitely. So, of course, there are many technicalities within Health Canada. But I think, especially as patients, having a voice, working with LLSC on these projects and the patient impact, I think that has a huge impact on being able to access medications. Unfortunately, because of the systemic issues and the process, there's not really a way to skip those steps. But I think having the FDA approval and using their evidence and their review, that can help your physician submit a request for a special access medication. And I think also, as a patient, knowing what resources are out there, like LLSC, like Drug Access Navigators, because of the rules within Canada with drug companies and advertising and so forth, it can make it very difficult to know what drugs are available and what's on the market. So having those resources to be able to put you in touch and put you in connection with drug companies and clinical trials, that gives you a good opportunity to be able to find out if there is another method of getting a medication in Canada before Health Canada approval comes. So, yeah.
So Haley, from when we were talking about some of these different access programs, was a question that came through us. How does Health Canada approve or not approve a special access program application? What are the criteria that they may use?
Oh, yes, good question.
Mhm.
It's it can be very, very tricky. There's not an easy answer. Um, so, Health Canada has a very broad and general form that a physician would fill out for any medication. So, whether it was for cystic fibrosis or for high blood pressure, it's very, very standard form. And sometimes these applications can be quite lengthy and a lot of back and forth with Health Canada trying to figure out what information are you looking for? What is that specific wording? So it can be quite difficult, but certainly having the clinical trial data, real life patient experiences, all of that is very impactful. So although it's a general form, anything that we can add to help present a case, I think is definitely impactful for the special access program route.
And I just want to also reiterate what Kaylee said and said, you do have a voice even in this process. So, especially in cases where, there hasn't been a lot of advances or it's a small patient population, just like you guys are all part of here. And so, in this age of social media, if you are part of a WM Facebook group, hey, what have you been your in access? What have been your experiences with this? This is my situation here. What have you used? And so having that sort of information and feeding it back to your working with your healthcare professional and saying, hey, maybe this one would be possible. Maybe this is going to be possible. And then working together, you may put in evidence that will help Health Canada make their decision. So within the special access program, we have to remember it isn't with all drugs, as Hailey was mentioning. It is only with those drugs that don't have any indication, is not approved in Canada for use. It is really for those very special cases. So even in the case of a drug that is maybe approved for CLL but not approved for Waldenstrom's, it would not be qualify for special access because it already has an indication here in Canada. But I really do encourage you to work and use your voice and work with your physician because this method has worked with some of the people that I have worked with. So, Hailey, we also had some questions in this age of precision medicine and precision oncology about accessing precision medicine and accessing targeted therapies. And they were asking about how retirees who might be on different insurance programs, what are some of the routes that they may use, and if there are some better or not as good in coverage for that.
Yeah, definitely. I can certainly speak to that. Drug coverage is very complex. The first thing that I can recommend to patients is please, before you're 65, look into drug coverage. We plan our whole lives, for retirement and savings and for all of that. It's so important to plan your health too. So look into your options. I see so often many patients, when they retire, some employers might cut off their drug benefits. And they have no idea. So, here in Nova Scotia, if you don't enroll into the Seniors Pharmacare program within 90 days of your 65th birthday, you get dinged a late enrollment penalty. And many patients don't know about that, but patients also put off, why should I have to pay this annual fee if I don't need any medications? So then you might save some money over a few years, but then in the long run, it might not provide as much value. So I definitely encourage you to look into your provincial funding. If you are covered with private insurance through your employer, find out what their options are. Find out if you're able to continue to pay for your benefits on your own, where sometimes employers might pay X amount and the employee would pay X amount. Perhaps the employee could pay the full amount in order to be able to continue those specific benefits. Um, and Also, there are options to purchase your own private insurance plan. Um, I I strongly suggest patients to look into all options before they make any decisions. I know it can be very scary and very confusing during this treatment time when you're uh, getting all these people coming at you with yeses and nos and approvals and denials and appeals. But just don't make any fast decisions. Take your time to research the options. Typically, private plans that you purchase on your own, you end up paying more money out of pocket in premiums and deductibles, and they provide very little drug coverage, or they might have exclusions or prior conditions. They might exclude treatment for certain medications because of that. So definitely look into all of those options first.
Thank you, Hailey. That was a really great answer. A lot of us, I really liked how you said a lot of us look into our RSPs, but we don't look into like our health benefits after for retirement. We don't necessarily plan for that. So that was a really great tip for those that are of us that are listening, and really for myself as well. Thank you. We also had, in continuing along those lines, there was also a question from some of the audience members that, why is it that a drug is covered? I have private insurance. Why is my private insurance not covering it?
Yes, that's an excellent question. So, how I mentioned with public drug programs, how they're carefully managed by the federal government and the provincial government, private drug plans basically have free range to do whatever they want. So a lot of these companies, they have what's called a formulary, which is a specific set of medications. Some of those formularies are very carefully managed, where medications may need prior authorization, or they might make you try a different line of treatment prior to X drug. Other private drug plans might have a less controlled formulary, where we would hear the term open benefits. So I often brag about the Sun Life Public Service, although that has changed to Canada Life now. Having an open formulary, it's either a yes or a no. It's either covered or it's not covered. So those formularies can be very troublesome, and they can be very hard to navigate. And a lot of that information is not public. So you're not able to research, will I be able to try this medication? And so that's where the value of drug access navigators come in, is they help ask those questions. They help do those calls with the insurance plans, because sometimes there's a lot of reading between the lines. And as a patient, if you're on the phone and they're giving you this information, you would expect that what they're telling you is 100%. But sometimes there is some information in the words that they're not saying. So, private drug plans, like all drug coverage, are very complicated.
Yes, they are. They are. They are very so much. If people remember back to the slide that I showed, the medications are becoming much more expensive in terms of cancer medications, and then from the insurance company standpoint, they too also want to manage the claims and the amount of money that they have to pay out. So for those that might be noticing a longer period, many of the insurance companies have instituted this process for high cost drugs specifically, where they say, we're going to wait for the CADTH recommendation. And if the CADTH recommendation comes out positive, then we will reimburse it. But if not, then we may kind of put this a little bit not so much on the formulary. We might evaluate it on a case by case basis. So I encourage you again that you do have a voice also in this process. For those of you that are retired and still are under a employee drug benefit program, or that are still working and or have a union, I really encourage you to talk to them, because if you find that the drug you've been denied coverage, the people who pay for the coverage are really the employer. And so, if you talk to them, then there have been cases where the employer will talk to the insurance company, and they can come up with a decision to allow you coverage on a case by case basis. But even though in that it says they say no, even if your union has helped advocate, you've said you've helped advocate for yourself with your employer, and the answer is still no. If you've taken advantage of the PSP, the patient support programs, and the other the avenues that might be out there, and you've decided, you know what, I'm going to go ahead and I'm going to pay some out-of-pocket costs, don't be afraid to go back. Don't be afraid to go back and re-ask and say, you know what, this drug is now working for me. Please reconsider coverage. And things change all the time. You know, there's things go through the CADTH reimbursement process, and you notice, oh my goodness, this drug is now reimbursed by CADTH. Go back and tell your insurance company it's now reimbursed. Please reconsider. So kind of keep knocking on doors is I think what both Hailey and I are saying. So in the chat box there's a lot of questions on expecting to go on zanubrutinib next year. What is the process they need to go through to get coverage on my drug? I presume your Blue Cross plan won't cover that. So I think, Hailey, we can't comment on individual cases, but maybe you would like to comment in general. What are some of the questions that they may be able to ask?
Yeah, definitely. So, in my role as a drug access navigator, this is something that we certainly go through on a daily basis. So, in a scenario where a patient has a private drug plan, whether you're considered a senior or not, the public drug program is considered the payer of last resort. So if you have a private drug plan like Blue Cross or Green Shield or anything like that, we do have to explore that option first before we can submit to the public plan. So what we would do in that case is we would contact your private insurance plan, find out if a drug is covered, how much they'll cover it at. If we need any prior authorization, we would get the physician to fill those out. Sometimes the process can be quite lengthy. I know some companies, since there's such an increase of demand for all medications, they're just swamped with these prior authorizations. So we've seen processing times upwards of 3 to 4 weeks plus, which as a patient with this diagnosis, that's scary when you hear it's going to be 4 weeks before we even look at your application. So that's where patient support programs come into play, because they can often help bridge in that initial preliminary period. And in the event that there is a denial, if we do know that the provincial plan has this drug listed on the formulary, or if they have formulary criteria, then the patient support program might be more likely to help bridge you until we get either an approval or denial from your private plan, and then we can look into the public plan. And so, as a drug access navigator, we usually look into these simultaneously, and it could be a lot of information. So, we never do anything without a patient's consent. And I try not to overwhelm you with all of the information and all of the what ifs. I try to take it one step at a time, focus on what we're looking at right now. Don't focus on well, what if they deny it, or what if the fax isn't received. Don't focus on that. It's take it one step at a time, and there are other options. On a particular case, say you had a Blue Cross plan, I do know off the top of my head that Blue Cross requires a prior authorization for zanubrutinib. And in the meantime, we could apply to a patient support program to ask for bridging supply. And typically, in my experience, since Waldenstrom has had a positive recommendation and is provincially funded, many private insurance plans have added it to their formulary. The process of prior authorization is more so to just evaluate what prior treatments have been used, and for them to kind of collect some data on their end. And in the event that they denied it, then we would look at the private or the public drug program.
So I'd like to sort of use this opportunity to echo again. Please, you don't have to do this alone. We can, as patient organizations, as drug access navigators, Hailey, and in our role here as a patient organization, we can help amplify your voice, and we can help explore your options. So if you have any questions, then please either make sure you connect with your the patient organization, whether it be WM or whether it be with us, and also you can also connect with the drug access navigators like Hailey, and we can really help explore all your options and in a really systematic way, and help advocate for yourself as well. So Hailey, do you think?
I wanted to add on top of that. Like I said, coverage and offerings vary across Canada and across the different provinces. And oftentimes patients might hear, well, a friend with the same condition in Ontario was able to get this medication, but why can't I? And oftentimes there are a lot of workarounds. Since there is so many rules with Health Canada and regulations, having those connections like LLSC and Drug Access Navigators, they're able to reach out to the drug reps and the drug companies. I've reached out to the global president of a company. I've had meetings with people that sit on boards in Europe to make a decision if a patient can access their medication. So certainly don't take no for an answer. But also, I find that there's a lot of mixed answers about program offerings. And around the wording. So, in the case of zanubrutinib, we often hear people ask, do they still offer compassionate supply? So the wording around that has changed for Waldenstrom's, where they have had that positive recommendation from CADIF and it is provincially funded. They don't necessarily offer compassionate, which means free on an ongoing basis, but they use the wording bridging, which means that they help bridge that gap. So if imagine 6 months ago, say Ontario added zanubrutinib to their drug formulary, we usually see Newfoundland and PEI are one of the last provinces to add something to their formulary. So in that time where we're waiting for those provinces to add a medication to their formulary, that doesn't mean just because you live in PEI that you can't get it. it's important to have those resources to put you in touch with how you can. So certainly reach out if you have questions about being able to access a medication, because oftentimes there are more things behind the scene that we might be able to push and escalate within drug companies.
Yes, and I want to emphasize that uh, WMers, LLSC, Odano, we all work together. So I may call Odano and say, hey, I have this case. Like, can you explore these options? I've already spoken to the pharma company, and we really work collaboratively together with that to help with your case by case. I have very, you know, we have 2 minutes left in our session today. Is that correct? Oh, 20 minutes. Perfect. So because there's been a number of different questions on here. And Hailey, there's something that's a follow up to that particular question. Do you know who can assist in the provinces that do not have navigators or a support program such as Manitoba? And I think in that case, it really again is encouraging you to reach out to your patient organizations, to the drug access navigators, because we can advocate for you on a case by case basis. We can look at some of the provincial avenues that are available. Even provinces that don't have it listed on their formulary, there are special ways. In Alberta, it's called director's privilege. In Quebec, it's called passion exception. In Ontario, it's trivium, and so we can try to tap into these case by case exceptions and also speak to the pharma company to see where we might be able to help. And even if we aren't able to get all the drug covered, we can perhaps help get some of it covered for you. I do want to put a little bit of a caveat on here and manage a little bit of some expectations, because all of these take time. If you and it is not these processes don't isn't something that we'll get an answer to in a day or two, or sometimes even a week or two. It does take some time for us to really dig, advocate, call, write letters, do a lot of legwork and a lot of persistence before we may get an answer. Would you say that's
Yeah,
correct?
definitely. Yes, can be quite lengthy process. And based on my experience, to add on to that question, how can or who can you reach out to for assistance where there are no drug access navigators, or where there may not be a patient support program? So this is an evolving role, and there's a very high demand. So certainly requesting this service within your hospital can help to push to have those resources added to your hospital. But also, there, I keep going back to the regulations around drug companies and their advertising. And so drug companies aren't able to directly contact a patient, but if you know a drug access navigator, um, I might know a drug rep in Atlantic Canada, and I could send them an email. Hey, this patient reached out to me. I actually did have this one particular case where a patient in Ontario wanted to be able to access zanubrutinib, but their cancer center didn't have a drug access navigator. So I reached out to the Atlantic drug rep and I said, hey, how can we get them this medication? And so the advice I gave back to the patient was, if you go onto Google and type in patient support program zanubrutinib Canada, that website is available to the public. So although I'm not in your circle of care, I can't enroll you into that program. I can help make those connections for you. And so if you go onto these websites, you'll find ways to contact them. So these are patient front companies where you don't need your healthcare provider to make the call for you. you can call them. And sometimes it can be tricky, but that's a workaround that we can kind of help expedite the process for some patients, where it's like, if you know this drug exists, um, and you reach out to a drug access navigator or a patient support program, they can kind of force things internally in your healthcare team to assist in making those connections to access a medication for you.
So, and even in those cases where there aren't drug access navigators in the province, you do have the support of the WMers, as well as patient organizations such as LLSC. So, if you made a call, let's say to Dan, and you said, you know what, I have this issue and I have this problem. If Dan didn't have those connections, he might call out to me, or he might call out to Hailey and say, "Hey, we have this. There's this case in Manitoba, and she's having problems. Can you talk to her?" And then we would be able to connect with the patient support program. We would be able to connect with the pharma company. The work of a patient organization does differ than that of a drug access navigator, because they do take up your case on a very personal level, and really helps you with even navigate your own private insurance, where us as a patient organization, we will give you the questions that you can ask your own private insurance, and it will be still you would still ask, but it gets more people into your circle of care, and more people helping and supporting you, so that we can help direct and guide your path and make it just a little bit easier. There's a question about the name of the Drug Access Navigator organization in British Columbia.
That is an excellent question. And I haven't done the research personally lately, I would say within the last few months. I can say, as the director of media for ACODANA, I handle the member registrations. So we have supportive members, and we also have active members. So I've actually had drug access navigators in British Columbia reach out to ACODANA to ask to be a part of our association, just to be able to gain access to our resources. So to my knowledge, at this time, there's not a formal organization. Like I said, ACODANA was just officially founded in 2019. So really, that was only 4 years ago. So even though we've been facing these challenges for decades, everything takes time. And I do anticipate over the next 5 to 10 years, if not less, that more of these organizations are going to become available. And I think bringing awareness to ODANO and ACODANO and the Quebec organization, that will help encourage these other provinces to create their own associations and to connect as one. Similarly, how you guys are all here as the Waldenstrom Foundation of Canada. You've probably all started with a small local support group, and then now you're all here helping each other and supporting each other. So that's the goal of ACODANA, and I hope that's what we can bring across Canada, so that everyone in every province isn't faced with as many barriers and has access to the same resources as other provinces.
There is a very geeky question that Daniel texted that talked about the chat. Is if you and asking if that Canada is the only developed country with universal health care. That's correct. That does not have universal prescription drug coverage. That is absolutely correct. And in my opinion, what extent would the creation of such a universal drug coverage program simplify things for patients and lower the cost of drugs in Canada? Very broad question, very geeky question. I love the question.
Very complex question.
I love the question. Thank you so much for asking it. Whoever asked the question, if you wanted to identify yourself, I'd love to have a geek out session on this with you. but I will try to answer it, and Hailey, jump in whenever and you would like to add something in a very broad term. So yes, in the very broad term, it would simplify things for patients because it does allow for different layers, and it does allow for drugs to be covered theoretically covered faster. But when we talk about universal health care and universal prescription drug coverage, the common myth is that this might be for all drugs, but it will not be for all drugs. They are looking at very common drugs, and we are uncertain yet what types of cancer medications might be covered under this. There will still be the process that it will need to be evaluated for reimbursement. There is still going to be the process that which like what is the price of this treatment going to be? So as we evolve through this, we as patient organizations, we've really been looking very carefully to pose these questions of the government when they've been asked for consultation. There's always been an opportunity for patient organizations to say, hey, from your perspective, what do we need to look at? We have been really making a submission every time to say, hey, we have to really look at how cancer medications are being covered. How are we going to tackle the costs? These are issues that we have to think about before we put these things on the list. And how do we decide which ones go on to the list? And then, wait, we've got a list. What if this medication doesn't work? How do things come off the list so that things that are working can go back up, can go on the list? So these are the what I always say is the treatments work, but the logistics of treatments are also important. So when we talk about policy and healthcare policy, we really want to make sure that the logistics of rolling out the healthcare policy is worked out and thought about before we open this up, so that we don't so that things can be as seamless as possible, as easy for patients to use as possible. So that's kind of a very broad overview and answer of the question. But as I said, I love geeking out on this type of questions. So if anybody wants to reach out afterwards, then I'm happy to geek out again.
Yeah, I'd like to just add on to that. The second piece of the question there, in your opinion, what extent would the creation of a universal drug coverage program simplify things for patients and lower costs of drugs in general? So the first thing that pops into my mind is, based on my experience and my personal opinion, I don't think that a universal drug funding program is going to lower the costs of the drug. I think the cost itself of the drug, there are changes with PCPA, and Christina, you can jump in here if I'm speaking out of term. I know there's a new process coming with the pricing of medications where a brand name comes out, and then when there's one or two generics on the market, the price only decreases X amount, and then once other generics become on the market, then it decreases more. So there are policies and procedures in place to reevaluate that, so that's why I don't think that a universal drug coverage is going to necessarily lower the cost, but I think it could lower the cost to patients. And oh, sorry, just one more thought there before I lose it. I just wanted to say that I think a universal healthcare would simplify things for patients in terms of having one standard formulary, not, well, in Nova Scotia, this drug isn't even listed on the formulary, but in Ontario, it's available through the exception process. So I think having a streamlined standard where everyone's on the same page is going to simplify the process route and not having to jump through all of these hoops for patients.
Yes,
And
and so you
yeah.
have to for those drugs that end up on the formulary. Yes, there will be definitely a streamlined route, but we have to. I think we have to be careful to remember that this will not be all drugs. So with people like Hailey, will still be very, very, very important in helping to. Her role might change a little bit, but there's in still figuring out what is covered and what is not covered. Again, we still encourage you to speak to all the tools in your toolbox that might help you access drugs. And Haley is absolutely right. Our healthcare system, if I may geek out for a little bit, and I think we have 2 minutes left in this session, but to say that our healthcare system is changing. We have to remember that when our healthcare system was designed, it really was designed for two bits. Very acute system, you either lived or you died. There was no overall 5-year survival. There was really not a lot of survivorship in cancer. So now, as we have all these innovative treatments that are happening, our cancer system is really struggling to keep up with the innovation. There are consultations about time-limited recommendations and about maybe we should, like in those cases, maybe like ibrutinib. We don't think the evidence is quite there yet, but maybe there's something there. It might be a patient benefit. Should we allow access sooner? And so these are evolving talks. Some of that goes back to how do we collect the data to prove that this is working? And these are some really outstanding questions that policymakers are asking and really trying to figure out. In the last minutes together, I just maybe ask Hailey quickly if you have some final thoughts, and then maybe I can wrap up.
Yeah. I think this was an excellent panel. I think between you and I, we both have a very, very good foundation between the systemic and the more detailed provincial and private issues. And most importantly, all I can say is just be an advocate of your own healthcare. You don't need to take no for an answer. The Google is out there for a reason. Yes, you can get into some bad information, but it can lead you. Use it as a resource. So I encourage you, look at these slides afterwards, review the links, and if there is a reach out, a way to connect, do it. The worst that can happen is nothing, but if anything can happen, that's a benefit. So that's the best piece of advice I could give you guys today.
Yes, and I'd love to echo Hailey before I throw you over to break, and really thank Dan and the team at WM for inviting us to discuss on this. I think we could have geeked out for quite a lot longer, but there was purposely a question that was in the chat that I did not address, and I'd love to address it in my final remarks. Is that WM is a small organization. How do you amplify your voice? But you do have a voice. And WM will always remain the number one organization in the country that best understands the community itself. And so we don't do things alone. We do at LLSC, we band together with WM to really amplify the voice. We band together with Hailey and to ACODANA and other patient organizations to really get what we want. And by banding all together, just as a recent example, we were able to get second dose of the COVID vaccine out to patients earlier. And that was a collaborative effort on behalf of all cancer patients. And so just because you come from a small organization, I came from a very small organization before I joined LLSC, don't think that you don't have a voice. You have a very loud and very important voice. Please reach out to us. Please connect to WMFC. WMFC and Dan and the team will connect to us, or reach out to us directly. If you, just two very quick things, even if you don't speak the language and have struggle with that, we at LSC can connect you to translators that have 170 different languages. I don't know how I didn't even know there were 170 different languages, but there are supports out there that can help you. And just remember to use your voice. So thank you very, very much for joining us today. And I will throw it over to break. Up next, we will resume break at 10:30 at 10:30 in 15 minutes, and then some new exciting speakers will be up next to talk to you about WM complications. But thank you so much for the time and space today. And I think both Hailey and I thought it was a privilege.